Dr. Ashburn, is to explain, we'll edit this down. I see you started to record, Mindy.
Yeah.
So we're tasked to do social action project, and so we wanted to ask you about some things about Medicaid and healthcare. And so thank you so much for making time to meet with us.
Sure, sure. Glad to do it. Yeah. Um, what's a helpful starting point?
Do you want to share a little bit about your background with us, your position? That would be great.
Sure, sure. I am born and raised in Dutchess County. Um, I'm retired from the military, retired from the Navy 21 years, 10 years ago now. I became a psychologist in the Navy. I was enlisted for about 7 years doing intelligence work and then switched over into an academic program where I got my master's and doctorate degree. Became a psychologist about 20 years ago, a little more. And, deployed to all the usual spots you would expect, except Iraq. Somehow never ended up there, probably for the better. Retired 10 years ago, returned here home. I work out of East Fishkill, living near my family, my wife's family, etc. And I've had a variety of different full-time jobs. A lot of them kind of, I would say, are fairly typical for somebody who's a retired military psychologist. I worked for the NYPD. I worked at some of the local prisons doing forensic work. The last 3 years, I've had a full-time remote job working for a management consulting firm doing assessments. The whole time along this way, sorry, now it's been closer to 11 years, I've had a part-time private practice in East Fishkill. Maintain a caseload of 35 to 40, goes up and down some. Some of that is long-term therapy. Some of that is assessments because of my background. I get referred a fair number of first responders, law enforcement, people wanting to join the military, but with a mental health background. So I get some kind of one-time assessments as well. But the bulk of my caseload is sort of ongoing, therapy work.
Thank you so
Sure.
much. So you really have really such a diverse background. And the topic we're looking into for our project has to do with Medicaid and healthcare. And so
Sure.
can you share with us, do you get many clients who are on Medicaid? Um,
Hmm.
do you have much experience in terms of working with clients who are coming to you because of that insurance?
I do. I get kind of a mix of managed Medicaid, through other companies, around here. Used to be Fidelis was super common, less so now. MVP, United Healthcare, and some other the big insurance companies locally. And then some, I'll air quote straight Medicaid, right? Direct Medicaid. I would say probably less than a third, but more than a quarter. So let's say if I have 40 people on my caseload now, somewhere between 10 and 15 have Medicaid in one form or another. I used to work at the Anderson Center for Autism. I was a director there for a while after I retired from the Navy. And so I do get, a fair number of people referred to me on the spectrum. So they may be registered with OPWDD and have some kind of disability, established who would use Medicaid, other people for income purposes who, are approved for Medicaid. So I get a fair number of people with, again, it's probably at its high, maybe a third, and its lowest, maybe 20% through the years.
Okay. Thank you for sharing that.
Mhm.
One of the questions we're looking at is how any proposed cuts to Medicaid might have an impact on mental health treatment for those clients who are coming to you or others, other providers. And just wondering how you see any proposed cuts maybe impacting your clients.
Yeah, I mean, I don't want to make the discussion too political, but certainly it's hard to avoid it to some degree, right? Um, the idea of a scalpel, model versus an axe or hatchet model, I think comes to mind, right? So I've certainly always been somebody who, working in the public sector a fair amount of my career, encouraged fiduciary responsibility and being thoughtful about how we spend people's money, et cetera. Um, Not the flip side of that, but another lens to look at this through, though, is that typically people who are using Medicaid One, their behavioral health needs typically are higher than people. I mean, there's good research on this, right? People that are Medicaid eligible from whatever pathway that they are eligible, they tend to have higher mental health needs than people that don't, right? So that's kind of always a moving part. They also tend to have more medical issues, right? Chronic medical issues. And there's always that interaction of, hey, if somebody's mental health can be worked on, then that's going to improve sort of mortality and quality of life because typically that improves people's ability to handle chronic medical conditions, hypertension, high cholesterol, metabolic syndrome, and these things that, are related to overall health. And again, the research is pretty clear. There's a good relationship between mental health and overall health. So, it would be hard for me to say in a real specific way without like knowing, okay, the federal government's doing X and New York State's implementing that Y, and that's how it's going to impact people regionally here. Um, but I don't now, and I don't know that I ever have thought, oh, there's so many people on Medicaid, like it seems like it's abused or something. Like I've never had that impression kind of working with people, that that's been a problem. Again, I'm not a numbers guy, so I don't sit at that perch. But ultimately, when you think of mental health care the same way as you think of regular health care, right? Cost, access, and quality, right? If you reduce if you make cuts, you're probably going to reduce access, and that's probably by default going to reduce quality because there's plenty of independent practitioners like me who take insurance and different Medicaid plans if, for example, just as one hypothetical, if they, cut reimbursement rates, let's say, there's going to be some proportion of independent providers who are going to go, hey, I can't work for that rate. Right. Right now, Medicaid is pretty competitive, right? It's not the highest, it's not the lowest, but it's kind of in that mid-range. So you're not taking a hit. Most therapists aren't going to take a hit taking Medicaid in terms of their overall revenue. But if they made cuts to it and made it more of an austerity or kind of a floor model, like, hey, we're going to pay the bare minimum, there's some percent of people in the industry who are going to go, oh, my rent's too high, my expenses are too high. So now that pool of people who would have saw these practitioners now are funneled to a reduced pool of practitioners like me, let's say, and or community clinics, et cetera. And and what happens with the waiting list there and quality of care there? Obviously, there's continuity issues sometimes in community mental health, right? Because a lot of times people are training, they're getting their hours, they're there, and then they go. So they're not as established yet in their career, and that can, create continuity of care issues. So it just cascades into a whole number of different problems overall.
Thank you so much. So I just to make sure I'm hearing right. So it sounds like two areas necessarily, that
Hmm.
relationship between the physical health and the mental health. And so if mental health care needs are not met or not met sufficiently, this could impact people being able to follow up on their physical health, but also the pool of providers
Hmm.
could potentially shrink, and that could impact care also in terms of access, but also for those providers who are providing Medicaid, there might be a longer wait potentially. Um,
Hmm.
does that, am I
It
capturing?
does. Yeah. The second part is basic supply and demand, right? Like reduced supply, same demand, right? You're going to have reduced access. And the first part, yeah. And again, I know, I think even Kaiser has some good data on the interaction of mental health and physical health, right? But, just think about it practically. It's like, well, who's super medication compliant with a bunch of medical conditions when you're depressed and untreated? Like you're not, right?
Right.
So you're decreasing quality of life, you're increasing healthcare costs ultimately, right? Because now you're going to be dealing with the downstream sequelae of the lack of sort of preventive and front end care, which always costs more. The further downstream you go, the more the care costs, right? So it's just a very kind of short-sighted way to run a healthcare model.
Thank you. We're going to move to Mindy. She's got the second question for
Sure,
you.
sure.
Hi, okay. So what do you think the longer term impacts will
Huh.
be of these Medicaid cuts?
It's a good question. Again, hard for me, always the caveat, right? I'd want to kind of know, you know, more specifics on it. But I think some of what we were just talking, Christina and I were just talking about, just kind of amplify and deepen that, right? If access is reduced and quality care is reduced, play that out over time, right? What is the kind of longer term, sequelae ultimately of that? Um, I think too, and maybe this is the limit or what's the right way to say it? Maybe this would only be the case if it was particularly extreme, but maybe not, right? There could also be just kind of system issues because people become kind of like, well, the system doesn't cover me. I've been in this spot and it doesn't cover me. So you end up with almost this ethical breach of like the implicit handshake of kind of like, hey, there are systems here to take care of you and have been in place for a long time. And now some population, some subset of those are reduced, whether that's direct or indirect. Direct might be they change the cut line of income, let's say, or disability rating or something. Indirect could be they reduce reimbursement for providers. Either way, when you're making cuts directly or indirectly, and you reduce the number of people on it, it's going to send kind of those little waves and shock waves out, across the whole ecosystem, and people will, not depend on the system and not think that it's a viable system as much going forward. And that impacts both the consumer but also on the provider side, right? You might have provider sides that go, hey, this is changing too much. It's a mess. We don't want to deal with it. So they basically shut the door to it at that point because they don't want to deal with with different changes to it or worrying that it's going to be cut again or so on. So again, you could end up with a kind of a downward spiral effect of that, which could be particularly problematic, right?
Yeah, thank you.
Sure.
All right, I'll be asking the next question. So we also want to ask maybe what are your biggest concerns about Medicaid cuts? Whether it's clients, certain types of client populations falling through the cracks, whether or not it's going to affect, larger communities, specific communities, or even how it would affect providers and
Mhm.
workers. Would it affect the workforce and such? Where do you see the biggest concerns?
Yeah, I mean, it's not a, it's, I don't think it's breaking news, right, to say, hey, if somebody is Medicaid eligible, the chance of them living in a low SES, lower support environment's much higher, having transportation issues is much higher, et cetera, right? I can think of several people I see, and I actually some of them I've seen for the majority of my time in practice now, who, if they had to go, for example, to the city of Poughkeepsie to a community clinic, or even like substance abuse, let's say go to Lexington up in the city of Poughkeepsie, they're not going to do it because of transportation issues, right? So there's this whole cascading, not to kind of, you know, pump bullets into that horse continuously here about the cascading effect, but it kind of bleeds out and spills over into all these other areas that are again going to reduce access and reduce overall kind of quality care. So at a micro level, I can easily see that happening. Like I can think of people that I see that would be an issue because they can't see me. Like these aren't people I could even do a sliding scale, for $20 a session. They don't have it, right? Like they are living paycheck to paycheck, and that's a stretch, right? So they don't have, there's no way for me, unless, if I have a pro bono case or two, okay, great, but that's not the same as 10 or 12 people on my caseload, right? So it ends up being creating this huge deficit, in access there. Sorry, you had a bit of a nested question there, though. Can you kind of repeat it so I make sure I hit all the notes with it?
Yeah, kind of also included, how do you think this would also affect providers, like clinics or workforce, that are work and kind of, I guess, collapsing or no longer being able to provide service, you know.
There's some, and again, again, the oversimplified model is you're either changing the threshold to access, right? Or you're reducing reimbursement or both in some level, right? Like that's oversimplified, but ultimately, like where are the points where there's money transacted, right? Um, when you reduce that, again, I think there are some clinics, just like some clinicians at the micro level, there will be clinics at the macro level that at some point, if it's that reimbursement piece, they're going to say, this isn't feasible for us from an economic, kind of standpoint. It's not, we don't have, we can't absorb the reduced sort of revenue, based on what we're doing. And that creates a complete access deficit because if there's cuts there, I mean, if somebody was to say, oh, but on the other hand, we're standing up, all these community mental health clinics are funding them on the back end to make up the difference. Okay, but I haven't heard any plans for that, right? So, there's a gap there, and there's no or perspective gap, and I don't see anyone kind of filling it. So you could have, again, I think the clinics survive, but they survive and they can absorb it maybe a little more than, a solo practitioner, let's say like myself. But at some point, they're going to have, that line too, where somebody who's doing their numbers and their books is going to go, hey, we can't continue this, right? We're not able to make payroll or pay our rent or keep the lights on kind of thing. And then again, when that happens and those people who could access care now can't, right? What happens? Now you have untreated, mental health disorders. Well, again, the extreme cases we all see on the news, people will talk about. It's one of the terms when I was at NYPD that I hated the most, and I still hate it, emotionally disturbed person, an EDP, right? And typically this is somebody with, an SMI, right? A severe mental illness who's untreated, and sort of hallucinating and being psychotic and doing something. Those are sort of the headline cases. But as we all know, that doesn't account for the people with untreated anxiety who become agoraphobic or they have too many panic attacks, so they can't go to work as much, or the people with untreated depression who, also aren't able to kind of activate themselves into the workforce and really kind of actualize in anything close to a Maslow'ian way that we all learned about, right? That they'll all those act as barriers to all those processes. And then you have to compound the medical issues that go with it. Because again, as we know, low SES neighborhoods, don't, in populations, they don't have the same access to medical care to start with. It's harder to get to. Medication compliance can be an issue, and that adds to the problem. It just cascades and downward spirals in terms of ability, to, the classic pull yourself up by the bootstraps. It's like, well, you're making the distance between my hand and the strap this much longer. Like I'm reaching, but how am I supposed to, kind of grab on, right?
Yeah, and I think most of it's done that I think can apply to our next question, which was what limitations and
Mhm.
services do your clients with Medicaid have currently, right, even before the cuts? Um, I think some of the things you talked about were like things like transportation being an issue for clients.
Mhm.
What about things like
Sure.
eligibility for testing, lack of access to certain treatments, the number of sessions allowed? Um,
Yeah, no, it's a good question. I think in general that, I didn't deep dive this with my population. I think it's I don't think there's a huge difference at my level. If somebody, let's say, comes and wants ADHD testing, right, and that's their presenting, question. In fact, I just had a local college student email me earlier about this, um, and interestingly, they have a, non-Medicaid plan. They have a college-based plan, and I would guess that that college-based plan is going to pay. I'm just going to estimate something around 25 to 33, about a quarter to a third percent higher than an equivalent Medicaid plan, right? Now, I'll, when I can fit the person in, I'll do it. That's not going to matter, but it is going to matter for some providers because they'll go, okay, I don't it's not still hard, like in terms of current procedural terminology codes, CPT codes, like how we code our encounters to get reimbursed, right? CMS has this huge list of approved and unapproved codes, that they'll pay X amount for this procedure, X amount for that procedure, right? We follow the same model as medical doctors and providers that way. It's not hugely different, but a lot of times the rates are lower. And there are some providers who won't do the service because they're like, well, um I'm not going to do basically do that job for that rate, right? It's not that they can't, it's just that they're going to go, well, if I'm doing that, then I have somebody else I could be seeing, like this college student who reached out to me recently or today, who I know I'm going to get a higher rate with because I've seen that insurance before and I know it pays well, right? So it's interesting because it's not something you can draw like a hard and fast line on and quantify, but I I mean, look, it kind of goes to the overall point of working in this industry. When I'm at a group practice, we're all solo practitioners. We're not all on the same insurance panel. Some are on some are on other. A few are on none. It runs the gamut. Old who needs an ADHD evaluation, inevitably there's two questions that are asked. When can a person come in, days and times, and what insurance do they have? So there's a bit of a soft screening that goes in at that point. And some of that, I'm just telling you, it's financial, right? So that's just a reality kind of that. You can get the things approved. They're just not typically approved at the same rate. You would think, I think common sense, and I would have thought, years ago that the administrative burden would be higher in Medicaid plans than some of the other plans. They're all burdensome. So there's not a huge difference at this point between, the paperwork requirement of a Medicaid-based plan versus a non-Medicaid-based plans. Actually, they're all pretty high. I say EAP plans are probably the highest, right? Because they have a lot of ongoing documentation they want you to do. But in general, it's not a barrier kind of in that way. It's more the soft barrier of, oh, what plan do they have? Oh, wait, how much does that pay for this procedure or that procedure? Doing the calculus in your head and going, I'll pass on that, right? So it's sort of a soft restriction on access and reduction in quality.
Okay. Um, I guess you kind of provided an example with, the college student you
Mhm.
mentioned, but would you be able to provide any examples, of course, within the limits of HIPAA, of any patients that might have been denied care or, had trouble accessing care, whether they were your own or patients that you
Mhm.
know of outside of your own work?
Yeah, yeah. I've had a few. This comes up more on the disability side, in particular the autism spectrum side. That you know, Most mental health practitioners are kind of generalists, right? They don't go, well, I can see people with depression and not anxiety, or I can see people with adjustment disorder but not depression or whatever. That said, there are some areas, sometimes they're personality disorders, sometimes, they could be things like eating disorders, gender dysmorphia, LGBTQ areas that have become kind of specialty areas where it really helps to have extra training in order to work well kind of with that population. And the autism spectrum is one of those, I feel like, right? A lot of good therapists can work with people on the spectrum, particularly if they're autism spectrum disorder level 1, what we used to call Asperger's syndrome. You can do the rapport building, relationship building, and kind of get there. As the cases get a little more severe, if they're sort of more into the 2 range, or they're kind of like 1, but they've got a significant density of symptoms, that becomes kind of a specialty area. I have been sent people who are OPWDD eligible and who are on Medicaid, um, people on the spectrum I've heard from them and sometimes parents like, we can't find anyone that'll see this person. And some of that, it's hard to know exactly why that is. I can't tell you with a surety. It's because they had a Medicaid plan. Sometimes it is that specialty piece, but I do just being in the business, I know how people think, and it's sort of additive. It's, you're thinking, well, when can they come in? Okay, what's the burden of the paperwork going to be? How much is it going to pay? What are the total kind of gestalt of working with this? Sometimes people add it up and they go, on the spectrum, has a developmental disability, they're OPW, DD eligible, and they have Medicaid. When I add it all together, that's just too much. I don't want to work with that person. So again, I've definitely been referred people who had a hard time accessing care, and I would hypothesize at least some of it was due to that Medicaid plan, but part of it's the whole cluster of things there.
Okay.
One final question for you, Dr.
Sure.
Ashburn. Thank you so much. This is really helpful. In light of everything you've shared with us, part of our project is to write letters to send to 5 elected officials. So, is there anything specific as we're going to legislators of different backgrounds to share with them about cuts to Medicaid, how they would potentially impact mental health care? Any message that you would want us to carry as we're writing those letters?
Yeah, and I mean, not to be too blunt about it, but it's like, hey, go talk to the stakeholders. Like you're elected by the electorate. Go talk to the people that are impacted by this. Ask them, what is it like accessing care? What is it like, worrying about whether you can, find a doctor that takes your plan or find a mental health provider that takes your plan. Like you know, it seems like a lot of politicians have no problem doing that when it's something that they know is going to be supported, right? And they're going to get support for. But, you're talking in general, like again, just generally speaking, Medicaid, right? Medicaid, I think Lyndon Johnson established Medicaid, right? 1965 or something, right? Like who is this for, right? It's for your lowest income, highest need, developmentally disabled. Like, what's the population we're talking about here? Like, go go see what they think about making cuts, and not under the umbrella that, well, you have to fund them infinitely at a super high level forever, but go actually see the details of what that's like. So you're making an informed decision, not just from a bookkeeping standpoint. And that matters. I'm not disregarding that. Again, there is a fiduciary
Sure.
responsibility piece here, but you're talking about people that they don't have other options. They're on those plans because they don't have other options. It's not like they can just go to their HR person and say, hey, I've had a major life event and I need to change from this healthcare plan to that healthcare plan. They don't have those degrees of freedom to work with. So I think unfortunately, I just think there's a fundamental disconnect between the people making those decisions and the actual impact on the ground of the people they're impacting. So anything that closes that gap, in my mind, would be helpful. At least if you get that input, you can at least factor that into your decision making.
It is so valuable and so well stated, and it's just been such a wealth of information you've shared with us from your experience. Just very thankful that you took the time to join us and to share your insights and your experience and your opinions with us. So just thank you very much.
Yeah. Glad to do it. Thanks, Christina. Thanks for the opportunity. Nice to meet you guys. Is this it
Sure.
for you guys? Are you done with your program at the end of this semester, or some of you got more to do?
Mindy, can you
Oh,
stop
okay.
recording
Okay.
for a
Yeah.
second?
Yeah.
Yeah.
That's